My name is Aylin Fazelian. I am a Social Democratic Member of Parliament and also a member of the Committee on Foreign Affairs. Now, next week, the government of the Netherlands will host a major conference on mental health and psychosocial support in emergencies. This is a topic that has received more attention in latter years, and for good reasons. The global mental health crisis is, of course, affecting all countries, but the consequences in countries in crisis are, of course, more severe. And this is not the least true when it comes to our children and young in countries of crisis, suffering from mental illness as a consequence of conflict, oppression, violence, despair, terrorism. So, we are very happy to today have two leading experts here with us to give us insight on this topic, to share their experience and thoughts on the way forward. Our first speaker is Professor Mark Jordan, Head of Research at War Child. And in addition to your professorships at King's College and Amsterdam University, you are also a member of the Interagency Standing Committee on Mental Health in Emergencies. And our second speaker today is Mrs. Gunilla Backman, Senior Health Advisor at SIDA, with many years of experience on the topic from all over the world, from countries like East Timor, El Salvador, Nepal, and with the UN. Earlier this year, Gunilla also received an honorary doctorate by Gothenburg University. So we truly have two experts here with us, and we're very happy to have you here. And we will listen to the presentations of our experts, and we'll have a chance to also have a discussion on the topic together, and a possibility for you also to raise some questions. So, with that said, I'll leave the floor to our first speaker, Professor Jordan. Please.
So what are we talking about? It's true that mental health is getting a lot more attention, and for very good reasons, as you were just mentioning. We're talking about 1 in 4 people globally that is suffering from a severe mental health issue or problem at any given time. Among youth and especially adolescents, we see that suicide is among the leading causes of death, sometimes even the number 1 leading cause of death. We see that there's over 400 million people that are directly affected, and the economic burden of mental health. So if you take all the mental health conditions together, it's been more than 50% of the overall burden. And if you're looking at, for example, the DALYs, which is like an indicator for how much burden a disease has on society, so it's a disability adjusted life years, it's an indicator. We see that 6 out of the top 10 are actually mental health conditions, contributing to more than 14% of the global burden of disease. So it's a real large contributor to overall burden. So that's kind of the problem. If we're then looking at the side of treatment in order to deal with that and the opportunities to deal with these sort of problems, we actually find that there's a near absence of mental health services, especially in what you see in the low and low middle income countries. This graph shows the number of mental health professionals, psychologists, psychiatrists, psychiatric nurses, to be able to respond to these problems that I've just outlined. And they are absolutely 1 to 1.6 per 100,000 population. So there's never enough mental health professionals to deal with the problems. So this is what has also been called a treatment gap. So the gap between the need for mental health services and the availability of treatments that are available. And especially in conflict-affected areas, we can actually see, and the latest figures that's come out this year, that there's a double the prevalence rates of mental disorders in conflict-affected areas compared to non-conflict-affected areas. So exactly in the situations where there's the most burden, the most prevalence, we see even fewer resources to deal with it. And that treatment gap is what we need to deal with. At this point, people in need, 95 to 99% of the cases do not get the care they need. It's as simple as that. For children in armed conflict, this reaches 99%. 99% of children requiring mental health services do not get the services. Now that, I think, is a true crisis. So what are we talking about if we're zooming in on children affected by armed conflict? Maybe first the numbers. I mean, when I joined War Child a couple of years ago, I'd been working on it, but I never realized how big of a group this is. If you're looking at children worldwide, just globally, and you're looking at the definition of conflict and conflict-affected populations, we see that 420 million children are conflict-affected. So that's more than 1 in 10 children worldwide lives in an area affected by armed conflict. Now you could argue, and some do, that definition is a little bit loose. So let's look at the areas where there's the most severe conflict happening. Think about places like in Yemen, in South Sudan, in the Democratic Republic of Congo. These places, and obviously in Syria. 142 million children live in those areas. So these are the children that we're looking at trying to support. So what is the conflict and what does conflict do to children? For a long time, a lot of academics have been looking into that and really looked at the impact of conflict in terms of psychopathology. So really looking at how frequent is post-traumatic stress disorder in people that have lived in armed conflict, or children in this case. And that is absolutely important because we do see that the rates of PTSD are much higher in conflict-affected populations. As I said, double the rates, if not more. At the same time, we find out over the last decade of research that looking just at PTSD is too narrow. The impact of war and violence is much more pervasive than just post-traumatic stress. It is also a much higher increase and prevalence of depression, but also sleeping problems, of aggression and social problems, problems with friends and other social problems. So we see that there's a lot more than just traumatic stress. And even if we're looking at beyond the kind of the psychological and emotional damage, we actually see that war disrupts, and this is not new, everybody knows this, but it's important to keep clear that the educational systems, schools are not functioning anymore, teachers are distressed and cannot provide quality education, or the social fabric of communities is broken and is disrupted, families that are broken up because of war and violence. We see an increase in child maltreatment and neglect and abuse. So basically, because of the pervasive impact of war on all of those areas, is what we're seeing children suffering from, and that translates to higher levels of depression or other mental health problems. Yeah. So how do we, as one organization, but among us also other organizations, trying to deal with this problem? Maybe important to keep in mind that the conference that is happening next year is only the second one ever to take place, that there's an interministerial meeting and conference around mental health. This one is the first one ever to focus on humanitarian settings specifically. So it's really a milestone in this field of work. If you think in 2007 is the first time that all the agencies working on mental health and psychosocial care came up with guidelines on how are we going to provide these services in acute humanitarian settings such as war zones. Before that, there were no standards, there was no agreement on how to do that. And in 2007, that was the first time that there was an agreement on those. And the agreement was very much to talk about different levels of care and making sure that we don't only look at those at the top of the pyramid, which is a public health pyramid, saying those that are the most severely affected. There are fewer, but most severely affected. They need care, but it's not the only care that we need. We also need to provide care for those that are maybe less affected, but at risk for becoming severely depressed. And even at the bottom of the pyramid, those people that maybe do not show any signs yet, but we want to prevent them from actually developing mental health problems. So those guidelines then, and following a public health approach, is really saying we need to target these problems at multiple levels. So in War Child, we are developing an approach that we call a system of care that consists of multiple interventions that are crossing these different levels of severity, if you like. So from people that are not affected, but we want to prevent from being having mental health problems, to those that already have severe mental health problems. So it's multi-leveled. We're also saying we want it to be integrated. So yes, it needs to be mental health problems, but we also need to target those other problems that I just put in the slides. If we don't focus on the educational system, we cannot deal with the stresses that children have. So we need to also work in the educational field. If we don't also target child protection and neglect and abuse, we cannot deal with the mental health crisis, because these are the determinants of the mental health problems. So we're saying we need to integrate those services. We're also saying we need to work socio-ecologically. Basically, simply, we need to work with children, but we also need to work with their parents, we need to work with schools, and we need to work with communities at large. And the last defining characteristics in our approach is we need to task shift. As I said earlier in the beginning of the talk, if we are going to rely on psychologists to do this work, we have to wait 50 years. And if that, it's going to take more than that. It's actually going to take 100 years or more to get enough professionals. So we need to rely on what we call task shifting. How can we train non-professionals to do the work that is otherwise done by professionals? And we are now in a process of developing the interventions to do that. So the care system that War Child is developing consists of 9 very innovative interventions that are developed to deal with some of those. To say that each of these 9 are dealing with a particular problem that we're trying to address. For example, dealing with issues of child abuse and neglect and maltreatment, but by activating the community to reduce child maltreatment. Or we have an intervention that is offering education and quality education to children that do not even have access to school because of conflict. And just being able to offer basic numeracy and literacy on tablets through serious gaming is a way to deal with some of those problems that children are dealing with. So really saying, how can we get a combination of these interventions together into a system? And I'm getting there. So don't worry with too many of these diagrams. But I will give also some practical examples. But for me, it's important to highlight another aspect with this slide. We are developing this care system, trying to deal with as many of those problems as possible, but with approaches that are innovative and new and not something that is out there. In order for us to say, can we research whether these approaches work? And this is very important, because if there's one thing that our field and our sector is lacking, is evidence. There's a lot of good intention. There's very little evidence of what works and what doesn't work, especially for children and adolescents. So what we have set out to do, and we're not the only ones, but we're certainly taking this very seriously, is for these 9 interventions, let's develop them, standardize them, and then evaluate the effectiveness. And if we can prove that they are effective, then let's see how we can bring these to scale so that as many as children as possible have access to those services. And that doesn't need to go through War Child. That any organization that has much further reach than ours should and can take these interventions once we've proven them to work and work with them so that we can actually reduce that treatment gap much more significantly than we do now. So we're investing heavily on researching the effectiveness of these interventions. But going one step beyond, even that is already a big step, but going a step beyond and say, once we have evidenced interventions, how then do you bring evidence care in real world settings and keep the quality? So we are developing systems to go about maintaining the quality of good services. Now that I think is the holy grail, and that's what we're after. So maybe to give you 2 examples of what these interventions look like, to give you a bit of a flavor. One is called EASE. It's Early Adolescent Skills for Emotion. It's an intervention we're developing together with the World Health Organization as part of a larger suite of interventions that are psychological treatments that can be implemented by non-professionals. So we're training people for 2 weeks, 10 days basically, to implement a 7-session intervention for children with severe emotional distress. So where normally these children would need to go to a psychologist, we're saying there is no psychologist. Let's train people, non-professionals, to do this. They get 7 sessions and 3 sessions for parents, basically to identify their negative emotions in order to be able to have stress management techniques, to have behavior and strengthen positive behaviors, as well as being able to deal with their problems. Now that's a new approach that we're developing together with the WHO and are in the middle of testing the effectiveness. No results yet. Maybe I can come back another time to share results, but the trial, it's a randomized controlled trial for the researchers among us, is on the way. So that's to give you one example. And the last example, and then I'll also stop, is yes, I said it before, it's very important that we focus and work with children. But if we are working with children on an intervention like EASE, and we reduce their levels of stress, but they go back to their home situation where the parents are extremely distressed and they're being punished and abused, then of course the distress and the trying to reduce this distress is a little bit pointless. So we need to work at all of these levels at the same time. So this is an intervention, it's called the caregiver support intervention, that focuses explicitly on the parents and the caregivers. And here the mechanism is that basically because of war, we know that parents are distressed. And because they are distressed, their parenting strategies become poor. I don't know how many of you are parents. I certainly know that if I'm stressed, even just because of work stress, I'm a poorer parent. I am not as responsive and emotionally sensitive as I am when I'm not stressed. Now that mechanism, that much more severe for in a war-affected country, delivers this mechanism. So how can we change that? So what we are now doing is an intervention that actually primarily looks at how do we first reduce the stress of parents and improve their well-being. Then talk about how can you increase your parenting strategies to ultimately improve the well-being of children. So this is a new intervention. It's being developed as we speak. We've done the first study. The outcomes, in fact, are very positive. We see that parents are more responsive, they're less stressed, and the parent-child interaction and relationship gets improved when we compare it to a control group that doesn't get it. So these are just 2 examples as part of a care system that War Child is developing in order, in our efforts to deal with this global crisis, to develop evidence-based care that can be taken up by ourselves but also others. I'll stop there and hand it over to Gunilla.
So I'm going to talk about slightly different. I'm going to talk about it from a donor perspective. And I mean, for CEDA this is a very important topic, but it's also a very challenging topic. So I wanted to share with you a little bit of what we're doing, what we've done so far, but also what are our thoughts and discussions internally regarding this issue. And what we have been trying to do. So what we have been trying to do so far has been to look at the research, what is being researched. But we haven't done so much yet, because we're starting to work in different areas at CEDA. We're trying to look at strategies at the global level, but also what bilateral strategies and regional strategies. We have done mappings and attending meetings and coordination to trying to understand what is going on, what are others doing, and then working and developing simple guides for our staff. Those are about things, and I will then go through a couple of them to just share with you what we have done. So we have the strategy here for Sweden's Global Development Cooperation in Sustainable Social Development 2018-2022. For those of you who are not sure, I mean, we see that run by strategies, and we are operationalizing the strategies, so to say. And this strategy in particular is at the global level. It provides guidance for regional and global levels. And here, within the sub-level enhanced capacity to promote healthy lives, it has decided that mental health should be one of the focus. It's also to try to integrate mental health and psychosocial support in the present revisions of strategies that are taking place. It should be kept in mind that the strategies, and that's what we are doing at the Asia and the Middle East unit, but at the end, it's up to the government to make a decision whether the suggestions that we make, whether they will be incorporated or not in the strategies. So this is a couple that are going on at the moment, and that has been sent to the Ministry of Foreign Affairs for a decision. So hopefully it will be included. Yeah. The other part that we're doing is also have been doing mappings. We're trying to understand also what is actually going on in our field, because the discussions has been that donors are not putting money into mental health, really, and we wanted to see, are we actually doing that? Or is it that mental health is creeping in under, for example, GBVs or SRHR or somewhere, but it's not explicitly stating mental health or psychosocial support? So there were two mappings. One was at the humanitarian level and one was at the global level, looking at what the global support was, but also what's going on generally. So what we found at the humanitarian one, that every contribution included something related to mental health and psychosocial support, but not explicitly. But the interesting part is the partners, they mainly provided support at layers 2 and layers 3. If you click 2 times, then we get to the next one. Yeah. So if you see the support that the contributions were were the community and family supports and focused on non-specialized services. So there was very little at the humanitarian, at the basic service and security, and not at the specialized level. So it's a little bit like what Mark has been talking about. So if we go back again, please. And mental health and psychosocial support is often linked with nutrition and water and so forth. This is just part of it, it's not the whole picture, but it just gives us a flavor of what's going on at the moment, and we are just trying to get a better understanding. Yes, next one, please. Yes. Then when we looked at it at the global level, at where they get funding from WHO and UNICEF and so forth, it also turns out that the global initiatives, WHO and UNICEF and so forth, also include mental health, and it's often hidden there within the GBVs. For example, our focus is very much on sexual and reproductive health and rights, and so forth. And also with HIV and AIDS, where there is also psychosocial support included. Yeah. But then, what are our challenges and opportunities? I mean, it's really positive that mental health is getting the attention it does. But at the same time, as we have been talking about, it's a huge and complex field, which Mark just highlighted as well. And how should we then work with this issue? And how can we, so to say, limit ourselves? And where is Sweden's comparative advantage in mental health? Should we work on prevention, or should we work on a curative part? Should we work on women and sticking closer to the feminist foreign policy agenda and SRHR, or should we, where should we be? So this is internally, we have quite a lot of discussions on this. It should also be kept in mind other issues that we are talking about is, what is the competence that we have in-house? Because it's also important to think about, yes, we all want to help, but what are we going to do not to prevent, not to do more harm? And this is extremely important. So this is also something that we are discussing quite a lot. What we have seen, so that's the sides what's going on internally. On the other side, when we're getting proposals, because I mean now there's this push, there's a lot of conferences going on, and of course CSOs and others are also now confronting us and saying we would like funding, or we would like to include mental health in our proposals. But what we have seen, and I'm not saying it's everywhere, but to one extent it's also, and you can start clicking, we got recommendations from these mappings, and they're very much in line also with the recommendations, the issues that we are facing and that we are discussing. For example, one thing they're talking about is the common framework and languages. Other things that we're seeing is the basic explicit mainstreaming psychosocial at a very basic level, and that is not always happening. Referral mechanisms, sometimes we're getting proposals and they want to set up their own services and not really linking it to referral services. Evidence-based interventions, very few, I have to say. Hardly any of the proposals that we're getting in mention evidence-based interventions. Perhaps we are not asking the right questions, but sometimes they actually don't appear or can't really answer to it. Monitoring and evaluation is something that we are trying to highlight as well. And then the other part is this. Now, a lot of times when we talk about mental health, it's very much being brought up in respect to conflict. But mental health is also in long term. So seeing this bridge between humanitarian and long term is extremely important. And there we need to start working much closer together and bringing, and we need to think about it long-term programming. For long-term, it's not just a year, but long-term programming. But also the actors, I think we need to work better together. And we also need partners to describe a little bit better how they build the local capacities and resources, so we are not setting up something grand and very expensive and then we pull out and then they can't keep it. Next one. And they ensure that the capacity building, as Mark has been talking about, is embedded in it. And then, yes, we have to talk about funding modalities. I want to just go back, it's fine. But I just want to say, I think why we're having this discussion is also because it's so easy to get trapped into the discussion about more funding, or we want to be part of conferences or so forth. But at the end of the day, we're talking about people. And I think we shouldn't forget this, and I think this is key in everything that we are doing. And although, as Mark knows me, I'm not here to talk about human rights, like explicitly, but I do think it does have a very important role, because it has not just been neglected, human rights within the health field, but it has also been one of the most neglected areas within human rights. And I think here when we're talking about human rights, and also from Sweden's perspective, we often tend to focus now on democracy. And I think it is important that democracy and human rights, and it includes all human rights, not just in terms of civil and political rights, but also economic, social and cultural rights, where we find the right to health, right to education, and so forth. So it all needs to be together. And we need also to have the gender dimension, because women and girls are very much impacted by this. And like Mark just mentioned, like when he talks about parents, mothers are often the ones to take care of the children. And if they are not feeling well and don't get the support they get, they will not be able to take care of the children. as well, and they are the future. So I wanted to take the opportunity to also to bring in a quote from Eleanor Roosevelt, although it's about human rights, but it was regarding the Universal Declaration. But I do think it applies also here when we talk about mental health. And it says, where after all the universal human rights begin, in small places close to home, so close and so small that they cannot be seen on any maps of the world. Yet they are the world of the individual person, the neighborhood he lives in, the school or college he attends, the factory, farm or office where he works. Such are the places where every man, woman and child seek equal justice, equal opportunity, equal dignity, without discrimination. Unless these rights have meaning there, they have little meaning anywhere. So, thank you.
Thank you. Thank you so much. I'm sure there are plenty of questions, but I'll actually start. That's the privilege of the moderator. So, if I ask the two of you, what are the 3 main challenges we face with regards to the global mental health crisis? I'll start with that question. And also, if you can keep 2 questions in mind, I'll add another one, and that is, what do you hope to come out of the Amsterdam conference? Please.
Shall I?
Yeah, you can start.
Because this is no. But this one, it's a great question, but I think the response might be a little bit cliche.
Mm-hmm.
I think the 3 that we need is resources, and I'm not talking just money and funds, but we need to. How do we go about getting enough people to provide this care? And that is such a mind-boggling problem that we know the mechanism, but nobody's actually demonstrated how we do this at large enough volume to really shift the needle. So I think resources is one. Second is evidence. If we're looking at the last 20 years worth of work in humanitarian sectors for children, there's only interventions for PTSD that have proven to be effective, none other one. So all the other problems, we don't know what's actually effective. That means that all the money that is being spent on mental health care is either being spent on programs that we don't know work or might not work, might actually even do harm or is a waste of money. So until and unless we can actually prove that they work, is it worth the investment? And we owe it. We owe it to the children to demonstrate that it works. We cannot just have that assumption because we all intuitively think that these are good programs. So I really think we owe it to them. And then the third one is the quality piece. I think there's been, if you're looking at it from kind of a 20, 30 years spectrum, there was a lot of focus on, hey, mental health is important. For 10 years, like burden of disease data. Now we're slowly looking at, hey, how can we go about it? And that's kind of what sort of treatments. But what we haven't looked at, how do you go about maintaining the quality of these interventions? So these would be my 3 things.
Mm-hmm. They're very similar. Yeah. I'd written it slightly different. I had written quality linked with funding. Yeah. But the other one that I have was also coordination. And I hope that this, I think also with the mental health, I hope it leads to also to opportunities, but also that we're also coordinating ourselves. But I think this is extremely important, so we're not starting to do vertical approaches. And that is it applies to the donors as well as to civil society and the UN agencies. And I think, it's just key. And then also evidence. But that we also take the evidence onwards and take it into practice when it is possible, so it doesn't just stay there. But this is also linked with the evidence when we know them, that it's also coordinated and we don't start to do new, take up new ideas. We're inventing the wheel. I think we are all responsible for this. So yeah, that's that.
And what do you hope that the Amsterdam conference will lead to?
Yeah. Well, shortly I do. I mean, one of the things it's also the coordination part and increasing networks for us is very much, and just the bridging this here also from conflict to long term. I think,
Yeah, for me it would be that donors and governments, we have all the information and the why it's important. The next step is that governments and donors say, yes, this is standard integrated part of humanitarian response. We cannot just see it as, oh, well, this is a luxury or only if we have money. No, it needs to be part and parcel of. This is, I think, a unique opportunity for governments to take that stand. So I hope that some will.